It relieves the pressure of us constantly saying, well, I need to eat breakfast. Breakfast is the most important meal of the day. I already got breakfast. I took care of it. I'm going to go on my day. So from there, we decide on a formula. And that usually, based on your medical history and what you can tolerate, what you're comfortable with. Usually they're provided by your home health agency. They bring you a giant case of them. And the different types, there's a standard formula that's just like food. Everything comes complex carbohydrates, fiber, protein, fat. Common ones at Stanford we use are Jebity and 2-cal-HN. 2-cal means that it's very calorically dense. It has 2 calories per ml, so you're getting the most bang for your buck with that one. And most people tolerate it pretty well at home. It is pretty heavy. If you try and drink it, it's pretty thick. So those two are more common for home regimens. We also use a semi-elemental if you have GI issues or you malabsorb pretty easily, or you're just pretty sensitive. The standard formulas feel really heavy and you just feel uncomfortable. Peptamen is the one we use at Stanford, and semi-elemental means it's partially broken down. So they've already kind of broken down the proteins for you into some amino acids, some more complex protein. The carbohydrates are broken down, there's no fiber, the fats are more in their fatty acid form. So it's just easier for your intestines to absorb the nutrients right away. And then the completely elemental is basically, we've done everything for you. You just feed it into your GI tract and your body can absorb it right away. Very rare for people to be on a completely elemental tube feed regimen at home unless they're a baby. They'll use it for babies. Or if you're pretty ill and in the hospital, then we'll use it. But most of the time, people are just fine. If you're able to eat regular food, you can do just fine with the tube feeds. The type of feeding tube, based on your individual preference, it's discussed with the patient and the family, usually bring in a gastroenterologist. Most common is the gastrostomy. It's actually small air, it's supposed to be a G-tube. And that's the most common one that people put, whether pediatric or an adult patient. It's a fairly easy procedure, they'll put it in. It can be taken out at any time when your weight gain is achieved and sustained. A J-tube is actually fed into your intestine, and we bypass the stomach completely. Most often considered if a patient has a lot of chronic nausea or they're very high risk for aspiration where they will cough up food or formula into their lungs, which we prefer to avoid so you don't develop pneumonia. Or if they have any other issues where we want to bypass the stomach, where they're feeling really full and bloated and they just don't tolerate, we'll feed them into their intestines. And an NG tube, not often seen in adult patients, but pediatric patients in centers will actually have pediatric patients will place their own NG tube at nighttime to run nocturnal tube feeds. Fairly common, and it depends on the comfort level of the family and the patient. So some centers do it. There's a lot of educational videos online if that's the preferred route. And it works the same as a G tube that feeds into the stomach. And then you just attach everything to your formula, set the pump, and then you're good to go. Parenteral nutrition, not commonly seen in cystic fibrosis unless you are in the hospital setting usually, or you're missing parts of your GI tract. So basically this is nutrition we're feeding you through the veins. For some reason we can't use your stomach, your intestines, your esophagus, something's not connected and working. So we bypass the whole system completely and basically give you your fat and your carbohydrates and your protein into your veins. So see it in the hospital setting. Oftentimes if anyone has obstructions and constipation and they just are not allowed to eat for several days on end, we prefer not to let you get malnourished, and so we'll give you an alternate form of nutrition. It is fairly expensive, so it's usually a last resort. Whatever the reason you need TPN, it costs about $1,000 a day to provide. So usually we consider it carefully, but we definitely don't withhold it. If you need it, you need it. Insurance will usually pay for it.
Can I ask a quick question?
Yeah.
Does that look then like you just have an IV?
Yep.
It feels the same way.
Yep.
It's just giving you nutrients instead of medicines.
Yeah, so it comes in a 1 liter bag, just like in a hospital when they give you IV hydration, they'll hang a 1 liter bag of normal saline. But it's yellow colored because we add vitamins to it for you. And they set it same as any other IV drip. They'll set a rate. Usually the rate and the concentration is determined by the dietitian and the pharmacist. And they'll set a rate and you don't feel anything. It's the same as an IV. And it just runs continuous, or we can actually cycle it and disconnect you for several hours. There's 2 types. There's total parenteral nutrition, where it goes through a central access. So when you go in the hospital and you get a PICC line placed or you have a Metaport in, those are considered central access. They're going into your bigger veins. So for that we can we can get in more calories and more nutrition if we can use a central access. Peripheral nutrition goes through peripheral access. Usually that's in your arm or your hands. Those are small veins. And we're pretty limited to how much nutrition we can give you. Because it's so small, those veins can't handle a lot of food and nutrition, or even a very concentrated IV going through. They're just too small, so it's too concentrated for them. So usually we're fairly limited, but most people don't require PPN for very long. We try and switch you over to the total parenteral nutrition or get you eating again is our goal. And so the dietitian would handle the macronutrients, so we'll do the calculations for your fats and your protein and your carbohydrates. And a pharmacist and a doctor would adjust if you need more sodium, do you need more calcium, how's your magnesium. They'll adjust all of your vitamins and minerals in it. So we provide for parenteral nutrition. The calorie needs are about 80 to 85% of your total needs for the day, because your body uses about 15 to 20% of the calories you're eating just digesting your food. So it's a fair amount, and since we're not actually feeding you in a way that your body is digesting, we're giving you the nutrition in the form that your cells want it. We actually kind of underfeed you, for lack of a better term, just meeting your basic needs and knowing that we're bypassing your GI tract, so we don't need to feed you anything extra. And usually if you're on sort of IV nutrition, our goal isn't for weight gain, our goal is to prevent malnutrition. We try not to give you too high concentration, because this is all metabolized in your liver. And after time, your liver, if we go too heavy, too quickly, or for too long a period of time, your liver gets a little tired. So we go carefully. And the composition is dextrose, are your carbohydrates, amino acids, the protein, lipids are the fats, and then we add vitamins and minerals in. So this would all be if you're in the hospital setting. It's a nice little yellow bag that they hang daily for you. A lot of times though, they'll run IV lipids for patients who are actually eating, but they're just not gaining a lot of weight. So they'll hang lipids, and it usually comes in a small pouch, runs through your IV line. It's kind of a white, milky looking formula. And the thought is that it might help you gain weight. It's just extra calories going into your cells. There isn't a lot of research for or against IV lipids. They haven't seen amazing weight gain, but they also haven't noticed any dramatic weight loss. So it might just be like a draw for it. There's a lot of questions of whether, because CF patients have altered fat absorption, does that affect how they use the IV lipids at the cell level? These are all stuff that's kind of starting to get researched and questioned now. With a lot of other different practices with cystic fibrosis, it's just a dynamic process that is constantly being researched. So it's used fairly commonly in the hospital setting where they'll order IV lipids. Whether it actually promotes weight gain or not, most of the time we just see that it doesn't prevent further weight loss. It kind of helps sustain you, which for a hospitalization might be a good thing. Rounding out the lecture, so hydration for nutrition in general is big. So we always ask, how hydrated, what are you drinking daily? In the hospital, you're probably getting IV fluids to stay hydrated. And it should be part of the daily diet. You should be drinking water is preferred, but just as acceptable, milk, juice. Sodas have some water in them, just to make sure that your body's hydrated. Oftentimes you're on antibiotics, you're on medicines, that you need to stay hydrated. That'll dehydrate you a little bit. For bowel regimen, for constipation issues, making sure you stay well hydrated, just to kind of move things through the GI tract. You don't want anything stuck. And illness. Oftentimes people get dehydrated and they can tell that they're getting sick because they're feeling a little off and they get dehydrated. And it happens pretty quickly. So usually if you have an exacerbation or an illness, most often you're probably dehydrated coming into the hospital or starting on the antibiotics. So being extra diligent during those times for staying hydrated. Weather, hot in summer, then you're going to be sweating more. When you're sweating more, you're losing more water. So it's important to stay hydrated. Then if you're on any sort of tube feeds or nutrition support, it's important to stay hydrated for that as well. So usually you can give, if you have a feeding tube, you can give yourself extra water through your feeding tube or you can drink it. It's pretty common for people to have a free water bolus, which is basically just giving yourself some extra free water right through your feeding tube. Physical activity, I try to talk about fairly frequently with my patients when I see them in clinic. In part to kind of promote healthy lifestyle. I also work with patients who get transplanted, and so it's pretty important that they're physically active and they have some muscle mass going into a lung transplant so that they can rehab well coming out of a lung transplant. The main focus is maintaining your muscle mass. So your body's burning a lot of energy, you're using a lot of calories daily, and your body will work through your fat stores and your muscle stores pretty quickly if you're not getting enough nutrition. And you aren't doing any sort of meaningful exercise to maintain your muscles. You aren't going to have any muscles for kind of walking or running or biking. So we encourage anaerobic or strength training, whether it's just kind of you walk up and down stairs and do little lunges, or you can do little push-ups, or you lift little weights. You do the WeFit programs. Anything to kind of preserve your muscle mass is important. And aerobic exercise is always important for preserving your lung function. So whether it's swimming or biking or running or hiking, walking, whatever you can do and can tolerate consistently is one of the other main things. Is if you can do something consistently, whether you can run 3 miles or you could walk 2 blocks, as long as you can keep doing it to maintain that lung function, then it'll positively impact it. It's also important for blood sugar control. Exercise is one of the big things to help keep your sugars under control because it helps your body. When you're actively using the energy, it helps pull the blood glucose out of your bloodstream and put it into the cells for energy. So that's why usually with diabetes you get a lot of pep talks about how active are you, how hydrated are you using all that energy that you're eating. And appetite and weight gain. A lot of people who are physically active tend to have a better appetite. And weight gain is more often associated with you putting on some muscle mass is the big thing. So, rounding out, these are 2 fairly well-established research papers kind of outlining the role of nutrition and malnutrition and its implications in cystic fibrosis. The CF Foundation website also has a lot of good resources. And then if you have access to Port CF, there's also additional nutrition resources, which some of the cards are actually available in the back for fiber and for fluids, etc. So those are easy, like quick reminders. That's the end of my presentation. If you have any questions, feel free to ask.
I have a question.
Yeah.
Our son is actually overweight, who has CF.
Mm-hmm.
His BMI is 27.
Yes.
So I would like to know, how does this impact his CF?
So being overweight is not necessarily a bad thing in CF. So a lot of CF patients, we just don't see the same other comorbidities as you would if a same male of the same age was overweight. But at the same time, it depends on his fitness level and his body composition. If he tends to be overweight and it's more adipose tissue kind of in his stomach area, that's not really benefiting his lungs per se. If his BMI was 27 and he was pretty physically fit and he just had a lot of muscle mass, that would be more positively benefiting his lungs, because then it would be extra muscle fibers and extra muscle building for his stomach and his abdomen and helping kind of with respiratory therapy and lung function. So it kind of depends which level he's on. If he tends to have more fat and more adipose tissue, then he could definitely benefit from exercise and kind of encouraging aerobic exercise. Not necessarily for weight loss, but to kind of change his body composition to promote muscle building for him. Does that make sense? Does that answer it for you?
Yes.
Okay.
Could you comment on the different nutritional needs for someone, say, who doesn't have CF and has diabetes? Someone who has CF and doesn't have diabetes yet, and then what happens diet-wise when that person with CF has diabetes? It seems like they're oppositional diets, but I don't know.
Yeah. So CF-related diabetes is little known about outside of the CF population, and can be very challenging if you have CF diabetes and everyone is trying to give you advice of like sugar-free beverages and you shouldn't eat that and please don't eat that cake. And there's a lot of advice out there that people are willing to give, and it's hard to say no and explain that like my diabetes is different from yours. But it's true across the spectrum, whether you have type 1 diabetes or type 2 diabetes, CF diabetes, gestational diabetes, the diet recommendations are different for each one. So for diabetes, you don't have cystic fibrosis, you may be looking at controlling your carbohydrates. You're really focusing on weight management. A lot of times they're obese patients or overweight patients who would benefit from losing adipose tissue, and that'll promote their cells to kind of use the glucose that's run through their bloodstream more effectively. They may get away with not needing insulin. They can take oral medications, or they can manage it by diet alone. With CF diabetes, you can't manage it with diet alone. It's very, very rare that we have a patient that can do it with diet alone, or they can even do it with oral medications. So a lot of times on the market you'll hear about metformin or glipizide or any of these oral medications that they promote and see in commercials, and they just don't seem to be as effective as controlling it. So with CF diabetes, your pancreas, the same as all the other organs in your body, has the genetic mutation. It's producing a thick mucus coating, and it gets plugged. So it's not producing the insulin, and it's not getting it out. So type 2 diabetes, you're kind of insulin resistant. Your body produces insulin, your pancreas is working just great, but the cells that need the sugar aren't responding to the insulin. And then type 1 diabetes, your body actually has an autoimmune disease and isn't making insulin at all. And then CF diabetes is a weird combination between the two. So we do an annual glucose tolerance test where we screen you for developing impaired glucose tolerance, where we can kind of track, like, you don't have CF diabetes yet, but your sugars aren't getting where they need to go in the timely fashion. So we kind of keep a closer eye on you. If you kind of tip the scales into CF diabetes, then usually an endocrinologist comes on board, or if you have a very savvy CF doctor who knows a lot about diabetes management. And you're pretty much instantly educated about insulin therapy. Because with CF diabetes, the insulin's just not getting out of your pancreas and into your bloodstream and helping your body metabolize the sugars. But your cells really want the energy, they want the sugars. So we give you insulin to help you with that. And most CF diabetic patients learn carb counting. So you still have the same calorie needs, the same nutrition needs as a CF patient. You need high calorie, you need your carbohydrates, you need your fat, you need your protein. But we need to give you a way to get it into your cells. So we'll tell you, okay, we'll figure out that, say, for every unit of insulin you give yourself, you need about 10 grams of carbohydrates. So there's like a 1 to 10 ratio, or maybe like 1 to 20. And the concept is that when you eat food, your body digests it, all the sugar's cruising through your bloodstream, and then we need to give you insulin to drive it into your cells. So most patients with CF-related diabetes have some sort of insulin to carbohydrate ratio, and they generally only take insulin before they eat. So you really only need it just when you're eating to get that energy in. And we may have to adjust, like if you get sick, your sugars may run higher, so we might tighten up your insulin to carb ratio and make it to 1 to 5. And we do that to kind of help you, but we don't ever limit. So we don't say you can't drink soda, or you can't eat candy, or you can't have buttered popcorn. Or we just tell you that you can have it, that's great. You need the calories. You just need to count it and give yourself some insulin so that you can actually make use of those calories, use them for the good. A lot of times we encourage balanced eating, because if you're going to drink a soda with diabetes, your blood sugar is going to go really quickly. Your body loves it, it'll absorb it really fast. Whereas if you maybe drank a soda but you had a turkey sandwich with some cheese on some bread, it's going to absorb a lot slower and your sugar's not going to spike as quickly. So it's kind of, those nuances would be similar to just a regular diabetic patient, whether type 1 or type 2, balancing your protein and your carbohydrates and your fats. But on the flip side, we don't restrict anything. There's nothing off the table. Unless you have a food allergy or a food aversion or for personal reasons or following a certain diet, we don't take anything off the table. We try and educate you how best to use the nutrients that you're getting.